my team feels that the lateral wall need not be augmented, and we three of us would try to convince you that it is really not necessary to augment the lateral wall. So in short, when we are talking of a comminuted intertrochanteric, unstable intertrochanteric fracture, what is the aim? The aim, if you have a fracture like this, or if you have a building like this, what are you supposed to do? You are supposed to support the inner aspect, or you are supposed to support the medial aspect, as you can see here. There are several complications of comminuted unstable intertrochanteric fractures like Z and reverse Z, uncontrolled collapse, screw cutout, so on and so forth. And the rival team wants to support the lateral augmentation, saying that if you do a lateral augmentation, all these things will not occur, or their complication rate will come down to 2% from 10%. I feel, and my team feels, that all this is because of bony instability. If you correct the bony instability, all this is not likely to happen. So what is our aim? Achieve stable reduction in these unstable fractures. That means convert this unstable injury into a stable injury. Avoid uncontrolled collapse. Strong intramedullary implants to physically prevent these collapse. So essentially, you have to have an upright head. See to it that the head does not bend. And then there would be no need for a to fix the flimsy lateral wall. Now, they are all the opponents are oceans of knowledge. They have published extensively. This is Dr. GSK's paper. This is Dr. Ganjare and Dr. Gadegone and my dear friend Dr. Pradeep Kotharia's paper. Of course, all three of them are my dear friends, but then their paper. And to top it all, it is Dr. Naveen Thakkar who has a silver jubilee oration to his credit on this topic. Yes, one is guts to challenge such a talented lot. And we three gutters have decided to do this task. And we feel that it is necessary to convert this unstable fracture into a stable fracture. The opponents have only hardware method. They just want to add implants. While we are part of software method. We need to understand, we understand the fracture and desperately try to get a stable reduction. And once you have a stable fracture, then there is no problem what kind of implant you use. Now, how do you achieve that? This is a hallmark paper of which was published in 2007 Journal of Trauma. Anterior and medial reduction of intertrochanteric fracture, a simple method to obtain a stable reduction. What the surgeon feels, and he has proposed, which has been borne out by several cases, that generally the intertrochanteric fractures like this. That means the anterior cortex fails in tension and the posterior cortex, and it produces a clean fracture line along the intertrochanteric line, while the posterior cortex fails in compression. So as the flimsy bone starts getting compressed, it breaks into several pieces and gets comminuted. If we try to achieve stability posteriorly, it is just not possible. And moment you try to do that, you feel there is a reasonable anatomical reduction, you try to achieve stability posteriorly, and invariably there is a collapse. There is a collapse and the proximal fragment just walks out, or what we interpret as the screw penetrates either inside or outside. On the other hand, getting stable contact anteriorly is possible, should be aimed. So if the anterior cortices get hitched, as you can see here, they just get hitched. Once they get hitched, it is very difficult that they move. Then you can put your assembly. Now there are some important questions. Is this anterior and medial column stronger than the posterior cortex? Is anterior cortex stronger than the posterior cortex? Is it less likely to get comminuted? So that in most of the cases you can use this method. Is it strong enough? This hitching is strong enough to remain stable post reduction and after fixation of only PFN without a lateral wall support? Then what would happen if there is an anterior comminution? Can bone grafting on the anterior-medial side help? Or then at least should we do lateral fixation? And most important, as Dr. Kulkarni said, that they are mobilized immediately. So can we, without a lateral fixation, allow patient to walk immediately, or we subject them to the torture of derotation boot, rest in bed, or non-weight bearing? Finally, if I swear by this, I have converted an unstable fracture into a stable fracture, then the rival camp will say, DHS karke batao. If it is a stable fracture, then DHS should work. So we will discuss all these points. This is a very nice paper, which has essentially, it was done for role of various anti-resorptive medicines and bone forming agents in elderly individuals. So as you can see here, the anterior medial cortical thickness is approximately 3 to 4 millimeters, while the posterior cortical thickness is just 1 to 2 millimeters. Another paper which has taken serial CT scans will show you that's the anterior cortex, that's the medial cortex, and compare it with the posterior cortex, which is very, very thin. So the anterior and medial cortexes are really thick, strong. Now, is it less likely to get comminuted? Can we use this method for almost every fracture? Yes. Out of these 101 per trochanteric fractures, 40 were non-comminuted fractures. Let's forget about it. But of the 61 comminuted fractures, all 61 cases had posterior comminution, and only 3 of these 61 or 3 of 101 had an anterior comminution. So only 3 of 61 had comminution anteriorly, and all 61 had comminution posteriorly. So if the anterior cortex is strong, and it hardly ever gets comminuted, so you can easily use to hitch it. So the aim is hitch the anterior cortex of proximal fragment with that of a distal fragment, disregard the comminution posterior or laterally, see to it that you do not have varus. Neck of femur does not like to bow in front of anyone. It likes to be straight, it likes to be erect. Moment you do that, then there is no problem. So for example, this patient, elderly female, has a comminution on the lateral side, has comminution medially, posteriorly. Now, the aim is match thick anterior cortex. Now, as you can see here, very often this is disregarded. Very often a dead lateral view is not taken, and somehow a guide wire is passed somewhere. The aim is to put in a spike anteriorly and see to it that you have a well-aligned hitched anterior cortex. Well-aligned hitched anterior cortex. That itself gives excellent stability, and then the patient starts walking as early as possible. Sometimes same day, evening, if you have operated in the morning, or say latest by next day, with walker of course, but they often go into on a stick within no time. So walker to stick in about a month's time, no support after a few weeks. She has been living all along in her village doing all her activities, and this is how she is at 4 years, completely consolidated fracture, as you can see, when she had a fracture on the other side just before lockdown. So several methods of attaining this are described. Several methods. You could pass a hemostasis, or if there is a posterior tilt of proximal fragment, one can do an intrafocal reduction. Put in a spike or a hook inside and lift up this as it is seen here. So if the proximal fragment is posteriorly displaced, then you need to use an intrafocal reduction. If it is anteriorly displaced, then you need to use some either a spike or a screw for putting it from front. And of course, Dr. Shivshankar's method of using a Shan screw is well known. He uses a Shan
Steinman pin, not Shan screw.
Sorry?
Steinman pin.
Steinman pin, sorry, Steinman pin. For he derotates and gets a good hitching anteriorly. Now sometimes there is global comminution. As you can see here, there is a global comminution. How am I going to get reduction? So as I said, it is biology and common sense. Aim is to get a reduction between an intact bone fragment in proximal and distal fragment. Intact bone fragment here and here. Just forget about the comminution. Forget about the comminution. If you have hitched an intact proximal and intact distal, it will have a very good hold. As you can see here, that's the intraop X-ray. We have just forgotten about the comminution, and that is at healing. Sometimes you may not be able to achieve a stable reduction, especially when there is a global comminution. I agree. Then what do we do? Now this is an 84-year-old patient where you can see it's global comminution. There is a significant comminution everywhere. What is the plan of action? Now I open reduce this. I put in a guide wire, I put in a nail. I agree that my entry should have been little more medial. Absolutely. With that, what has happened is I have a big gap here, and this is a pictorial representation of a C-arm lateral image. You can see there is a big bogda, big gap there anteriorly and medially. So I have not been able to achieve a good valgus and good anterior reduction. Now this is after I have put in a nail, and now to do everything all over again would have been too cruel. I would have possibly shattered more bone than what I have done. So do we put in a lateral plate now? No. What is the aim? It defeats our theory. One has to have support where there is a pathology. The pathology or support is needed anteromedially. So can I improve it? Will it eliminate the need for lateral fixation? Yes. You can see the bone graft is available there. So we dissected my junior Aditya Menon is a strong person. He could easily fish out the lesser trochanter and punched the lesser trochanter into this gap, as you can see here, anteriorly and medially. Now, unfortunately, she developed early surgical site infection. I had to explore, I had to debride, and at surgery, I realized that there was a granulation infective tissue deep here. So I excised the lateral wall. Now I don't have any lateral wall. I don't have a classic valgus reduction, but I have my hypothesis or Carr's hypothesis of anterior-medial reduction and a good stability anterior-medially. Many friends told me, "Ye to gaya abhi." But it was the anterior-medial stability that saved us. You can see she never looked back. This is at 8 weeks. She was walking very comfortably. We started her on teriparatide because she was severely porotic. This is at 9 months. You can see very good consolidation. And this is at 2 years. Completely consolidated fracture. So the uncontrolled collapse was prevented by strengthening the anterior-medial aspect, because that is the ranabhumi, that is the site of pathology. You cannot support it by putting a lateral plate.
Vikas, I will interrupt you.
Yes.
The previous case, you were little lucky. Yeah, because it was a negative cortical support. There is a minimal. Whenever the beak is inside the distal medullary canal, it's always varus. So in spite of that, it has united. You are lucky. That's all.
Yes. Only thing is, I created a anterior-medial support. If you
you accepted the varus for the stability.
I accepted varus.
It is a trade-off.
I am not saying that I did not
Varus means it is bound to fail.
I
Luckily in this case it has united, but varus should never be accepted.
I agree.
No. You think it is a virus here? In
Yes,
this
sir.
X-ray, you think there is a virus here?
Beak has gone into the distal medullary canal means it is varus.
एक मिनट शिवा. You
Sir.
seeing the X-ray? If
Yeah.
you measure the angle, is it in virus?
Yeah,
Sir,
yes,
see the
sir.
right side. Sir,
It is
see the right
125.
side. Compare the right
125.
side. It is not at 135. It's more than 140. Right side. You see the normal X-ray. That has not been restored on the left side.
Yeah.
Yeah.
I agree that there is little virus. As I said, I realized after, because it was just a bugda, and I realized that
For the
taking out
people who
nail-
don't understand Marathi, Bogda means void.
void,
Yeah.
yes, a big void.
And here, Vikas,
Yes, sir.
you are mentioning you have removed the lateral wall, but इधर तो दिखाई पाता है भाई.
No, sir, I will show you. See
Picture
this,
baki.
I have taken out the lateral wall here.
That beak only. I think
this.
you have taken away that beak only.
See
Yeah.
this, and see this.
Because all the remaining lateral wall is there.
There,
Sir,
yeah.
from here to
Only
there,
From
from here to there, I have taken out the lateral wall. This is
You
that's
have
the
removed,
dominant
you have not
tubercle,
removed,
and it's almost
you have not
10
removed
centimeters
the,
of-
trochanteric part.
He has just trimmed the tip, the beak. That's all.
exactly,
that's all.
exactly.
Yes.
So if I can add, if he has trimmed it, he is not fixed the lateral wall. There is
Not fixed
virus.
the lateral wall.
The lateral wall has not been fixed. Whether it is
But
excised or not
that
not there. So-
is why it has gone into the virus.
No,
the
If
lateral wall
if
has
the
not
lateral
been fixed
tension,
because of
if
the
the lateral
medialization.
tension, if the lateral tension band was corrected, it could not have gone into virus.
So if the
Ultimately, we
lateral
need a
wall-
function. Ultimately, we need a function.
No, the
Naveen-
lateral wall. if it
Naveen
was
bhai,
not
picture
fixed,
baki hai.
The,
No,
the
Naveen,
whole virus, the
if you
fracture
see
would have collapsed. If the lateral wall was
immediate
that
post-op
significant.
X-ray and 2 years X-ray are same as regards the angle is concerned. The angle has not changed over a period of 2 years.
Yes.
you
You can
can-
No,
please
no.
continue.
Once
We accept that.
it is stabilized by bone itself, by the collapse of varus, it stays there, but it unites in the varus. That is the problem.
So what, see, by putting a lateral fixation, my varus would not have been corrected. My virus would not have been corrected.
But initially, the first surgery, not the second surgery.
So Naveen bhai,
It was the
Naveen
first
bhai,
surgery. It was the
Naveen
first
bhai.
surgery which was important.
Eight
Only the
seconds.
first surgery, the soft tissue is not good. In the second
Okay.
surgery, already there are contractures.
No. You are making a mistake. You have not realized what I am saying. She developed early surgical site infection.
No. In the first surgery, you put that lesser trochanter inside the gap.
Correct.
And not reconstructed the lateral wall.
Correct.
The lateral fragment, the fragment was going in abduction and coming out.
Correct.
It was jutting out. It was not in the flare of the lateral wall.
Yes.
And exactly there was the screw going.
Correct.
So
what
there
I'm-
was laterally deficient, and so that has gone into the varus.
No, what I am trying to say is, you see the immediate post-op X-ray.
Yeah, that's why
There
that
was-
was.
No.
Sir, can you show us chronologically, sir, please?
Yes,
I'll show you
Dhaval
again.
wants to say, moderator Dhaval.
Yeah.
Dhaval,
Dhaval
we have
wants to
not
say
got
something.
chance for him to speak.
Yeah.
Dhaval bhai.
We have to take Dhaval's permission to speak.
Yeah, that's what. I
Follow
think
Dhaval
because you
ji.
should continue.
Okay.
But
Yeah,
Dhaval is doing
we'll
other work.
take that with a pinch of
What I
salt.
am trying to say, that there was a little virus to start off. I agree. I realized on table after I put in my nail. Now, after putting my nail and a blade, I don't think by putting a lateral plate, my virus would be corrected.
No. The reduction has to be corrected. Then and
That
then
is-
nail.
So that cannot be achieved by putting a plate on the lateral side.
But that could have corrected by removing the nail and doing a reduction and then adding it.
I totally agree that.
एक minute, Naveen.
Yeah.
The debate is lateral wall support or no support.
Yeah, absolutely
So
right,
that
sir.
has nothing to do with this. Even if the lateral wall was broken, he has not supported it until it is held up. What you are saying in virus, that is एक minute, Naveen.
कितना वारस है नवीन?
जो whatever is the small virus
15
which is
degree.
there, It is to do with the reduction. It has nothing to do with the lateral wall.
Correct. There's nothing to do with lateral wall. So in spite of lateral wall not being supported, with a little varus, the fracture united because I created an anterior-medial structural stability. That's all I'm saying. The angle has not changed from post-op to 2 years. As you can see here, this is an immediate post-op X-ray, This is after I have excised, that's the innominate tubercle, and that's about 3 centimeters below. That is the lateral wall I have excised
lateral wall.
after she got infected. Then this is the stability that we have created. This is at 8 weeks when she has started forming this lateral wall. This is at 9 months when she has almost formed this lateral wall, and this is at 2 years. The angle has not changed and she has united well. The fracture has not collapsed. The fracture, there is no cutout of the screw. There is no cutout of the screw.
It becomes stable.
Yeah, it became, so by adding a lateral support, I would not have achieved anything the stability was needed on the anterior-medial side, which I have given. So anyway, so then
I have measured the angle and Agashe sir, it
Yes,
is
please.
29.
Huh?
I have measured the angle of your this presentation
Huh?
of a final slide and it is 129.4.
129.
Normal side. What is the normal side? No, Gadegone.
Yes,
What
sir.
is on the normal side? You have to measure that also,
Pelvis
because this
with
patient
pockets.
is in a severe valgus.
Yeah.
Yeah. Yes. Okay. Proceed, Vikas.
Okay. So if the reduction is not that important, then the theory should work with DHS also. So next few cases are before I started doing intramedullary drilling, and by intuition I used to get anterior bone-to-bone contact. Here is it day 1 failure, and at 3 months she has healed. This is at 1 year. Another one, thin
Can I
lateral
add,
wall.
sir? Can I add for DHS negative reduction is better?
No, I think it will
Negative reduction, because you made that big inside to get the stability here.
Yeah. So this is
In
at
DHS that gives the valgus. That gives the valgus, sir.
this is at 10 weeks. This is at 5 years. Another one, valgus, anterior hitching, healing. So this is just to show the importance of anterior-medial reduction. Of course, today I am nailing for these fractures with a lateral wall deficiency or fracture for various reasons. One of them medico-legal, because it has been instilled in our mind that no lateral wall, no DHS. Finally, friends, we don't intend to do any mud splashing. They're all oceans of
After doing the mud slashing, finally we do not do the mud slashing.
So we need to critically analyze and not criticize their papers. By that I mean there is a scant respect to reduction in all these papers. Here you can see, using image intensification, a close reduction is performed to anatomical reduction. There is no mention of anterior hitching. Same one here, all cases are screened to check reduction in AP. And as far as Dr. Naveen Thakkar's thing is concerned, he has said limitation of study is reduction quality. Obviously, it is very, very difficult to achieve.
No, sir. No, sir. This slide is for sir finite element analysis.
That is exactly what I'm saying.
We have kept these factors constant. So then we can study. What we are talking is, if the reduction is perfect, still does the implant makes any effect? That is
correct. So the reduction per se, as far as finite element is concerned, it is very, very difficult to get a good stable reduction with finite analysis. That is what you have said.
With finite analysis, reduction is controllable. It is controlled. That factor is controlled on the computer. Quality of the bone is controlled on the computer.
Okay. So
But
what do you mean
the
by reduction?
only BK
एक minute. If I can suggest,
Yes,
I think we are going off the line.
Okay, sir.
We just finish the thing
Okay,
and
okay,
then we
okay.
will discuss
Yeah.
because I think we are going off the
Yes.
line.
Okay.
Okay, sir.
So to summarize, friends, a good reduction in AP and lateral is important. Stable reduction, non-valgus or non-varus or valgus reduction, maybe with a positive variance. So friends, be a gardener and not a carpenter. Thank you, friends.